So, intracardiac tracings for the cardiology boards, just very few things you need to know, and it's actually was just covered pretty much 99% of what you know in this question that was just presented. But you have to understand, recognizing this His bundle electrogram, and figure out the level of atrioventricular block. Some very simple tracings related to diagnosing ventricular tachycardia versus supraventricular tachycardia with intracardiac tracings. And all of this we'll cover in the next few minutes. You don't need to know anything complicated. So there's no complex maneuvers, biophysics of ablation, nothing complicated in terms of intracardiac tracing. So we'll keep it simple. And pretty much what I'm going to talk about over the next 5 minutes will be really all you need to know in terms of the boards. So this His bundle electrogram, so you know wherever you take a catheter and you stick it somewhere in the heart, it records the local electrical activity, and that's called the electrogram. The EKG, on the other hand, is like as if you had electrograms all over the heart, and it's just mapping the whole electrical activity of the heart. So local electrograms, if you have this catheter in the atrium, you'll get a local atrial electrogram. It's like a local P wave. If you have the same catheter that moves into the ventricle, you'll get a ventricular electrogram, which is like a local QRS complex. Now, if you take this catheter and put it somewhere where the His bundle lives, you know the His bundle is somewhere near the annulus, so you will record both atrial and ventricular electrograms. So if you see here the EKG, P wave, and QRS, and you drop a line down, you'll see one electrogram which lines up with the QRS, one which lines up with the P wave. This is the atrial electrogram, the ventricular electrogram. Now, as the current travels from the atrium to the ventricle, it crosses through the His bundle. And this His bundle generates its own local deflection or local electrogram. That's the His bundle electrogram. So you can just kind of picture it in your mind what's happening in the heart as you record this. You have atrial activation, then you go through the AV node. Notice as that current is traveling through the AV node, it's silent. There's no electrogram that's generated there. Then all of a sudden you have this His bundle spike, which is the current has reached the His bundle. And then after a while, it travels down to the right bundle, exits, and generates ventricular activation. So A, His, and V. Between A and His, we've got the AV node. Between His and V, we've got this time that it takes to exit out and come back to the ventricle. So now you get a tracing like this, and it always starts by looking at the EKG. You'll recognize sinus rhythm, right bundle branch block. Then you have these. You have a ventricular electrode. So notice how that times with the QRS complex. Then you have an atrial electrode. That times with the P wave, and then the His bundle electrogram that has 3 deflections. Everyone should be able to recognize this, and then we can measure some intervals. From this atrial electrogram down to the His is the AH interval, and this is a reflection of how much time it's taking to go through the AV node. From the time you get the His bundle electrogram to the start of ventricular activation, that would be the HV interval, and that's a reflection of time to go down the bundles, right and left bundle, and get out into the ventricular myocardium. Now take a look at this here. So typical kind of tracing you could get in the boards. Look up here, and you'll notice there's some irregularity. You look down in the electrograms, you see a pacing spike. The pacing spike followed by an atrial electrogram, then the His, and then the ventricular electrogram. Again, you just find the QRS and draw a line down. You'll know which are the ventricular electrograms. So you see A, His, and V. Now look at this for a second, and you'll notice something is happening. From the pacing spike to get to the His is taking longer, and then you pace and captured the A, but you never made it to the V. There's no QRS here. Where did it block along the way? Key question is, did I make it to the His at all? And you notice here it's A, His, V. Here A, no His. And back here again it's A to His and V, A to His, but taking longer, and then V, and then A, no His. So two things here. You notice this Wenckebach type phenomenon where it's just getting progressively longer before it blocks. And you also notice that where it blocked was within the AV node. So this is supra-Hisian block, same as Mobitz 1 type block, same as saying that block occurred in the AV node. Now take a look at this tracing. Again, start by looking at the EKG, the surface EKG, and you'll notice P wave, QRS, but QRS is wide. Same thing, there are no dropped beats. Now look down at the intracardiac electrodes. You've got atrium along with the P wave, ventricle along with the QRS, and you've got the His bundle electrogram. First, remember, you're going to see 3 electrograms here. You're going to see A, His, and V. But you'll notice now the delay is between the His and the V. Why would it take a long time to get from His to V? What's in between? It's the infrahisian conduction system. So the bundle branches, the His-Purkinje system. So these usually conduct very quickly, between 35 to 55 milliseconds. So if they're taking a long time, and that's where the delay is, this is some disease there, some infrahisian conduction disease. Now in this patient, you start pacing the atrium. So recognize the pacing spikes. Right after the pacing spike is the P wave. Right after the pacing spike in the intracardiac tracing is the atrial electrogram. Notice when you have a conducted beat, you have pacing spike A and V, you look at the His bundle electrogram, you see atrial electrogram, His, delay, and V. But now in this next beat, where you have pacing and capture of the atrium, but no QRS complex, the block occurs after you see the His bundle electrogram. So you made it through the AV node. That wasn't a problem, but the problem is once you got to the His, you couldn't get to the V because of infrahisian block. So infrahisian block means you see the His, but then you don't see the V after that. Infrahisian block means the problem is in the bundle branches or the His-Purkinje system. It's the same as Mobitz 2 type block. It's the same as infrahisian block. It's the more dangerous type of block, as you know, because you have less chance of having an escape rhythm that's stable, and most of the time patients will get a pacemaker with this type of block. So once you're able to recognize suprahisian and infrahisian block, you can pretty much, if you like, just tune out and you're done with this preparation for this part of the boards. But just in case, you can follow along for a couple more slides. So here, notice what's happening here. Here there's 2 things happening. I'll give you a second to look at it. Here you pace, you make it to the A, then you make it to the His and the V. Now A, make it to the His, make it to the V. So delay is in the AV node. Make it to the A. You capture the A, but no His. So something we saw a few slides ago, suprahisian block. But the second issue that's happening here is you are pacing the atrium, and then you quit pacing the atrium, and it took time. It took a long time for that sinus node to wake up and then start beating on its own. So here, this patient not only has some issue with the AV node, but the sinus node is also not normal. It's taking too long to wake up. Everybody, if you pace the atrium and suddenly quit, or you have AFib and the AFib suddenly quits, it does take time for the sinus node to realize it's time to start beating again. But some folks with sinus node dysfunction, it takes too long. In the EP lab, you don't need to remember this number, but if you measure this interval and then just subtract it with what the patient's natural sinus node rates are, and if that difference is more than 500 milliseconds, that's too long. But just remember, it's possible to also get an idea if the sinus node isn't working well by just pacing faster and seeing how long does it take to come up. Why do you think this patient would have both an issue with the sinus node and the AV node? Well, the most common scenario where there's a simultaneous problem with sinus node and AV node is an autonomic issue, usually too much vagal tone. And one of the contexts that we see this is during a tilt table test. In a tilt table test, for example, if it was done and you had intracardiac tracings, you could have a period of a sinus pause, but when there are sinus beats that are possible or you're pacing the atrium, you'll also get block across the AV node. So good rule of thumb is if you have tracings, Holter, EKG, intracardiac, that show both sinus slowing and AV node block, Mobitz 1 type AV block, some issue with the vagus. So in the setting of, say, neurocardiogenic syncope. Now take a look at this one. Now you'll hear in some talks about how you can use the EKG to tell whether it's SVT or VT when you have a wide complex rhythm. And actually it can be very hard. And even after doing it hundreds of times, you make mistakes. But for intracardiac tracings, it's extremely simple. It's extremely simple to make this distinction. So let's follow this on this. If you look at this EKG, you see just, well, this is a wide complex tachycardia. I don't know what this thing is up here. Is it part of the QRS? Is it a P wave? But then look at the intracardiac electrodes once they're in there. Ventricular electrode, it's like a local QRS. So every time there's a V, there's a QRS. They line up. So that's all ventricular activation. Then you look at the catheter in the right atrium. That's recording the P wave. So no guessing where the P wave is. You just look at it and you'll know this is when the atrium is getting activated. Notice there's only 3 of these beats in the atrium, and there's like 6 of them in the ventricle. So there's more V's than A's. There are more QRS's than P waves. No longer a mystery. This is ventricular tachycardia. So it's fair to have a tracing like this and someone asks, what's your diagnosis, or what will you do? Will you put a pacemaker or an ICD or some variation of a question like that? All you need to do is look and see the ventricular electrograms, the atrial electrograms. If there are more V's than A's, it's VT. If there's more A's than V's, it's some kind of SVT, usually atrial tachycardia. If there are an equal amount, then it's very difficult to tell, and that's something more for like folks who are doing an EP fellowship or something like that. But when it's like this, more V than A, no problem. This will be ventricular tachycardia. Look at this one, just a variation on the same thing here, except here you see a wide complex tachycardia. Then you notice that you have V's with every RV electrogram lines up with the QRS. But we don't really have an atrial catheter. Sometimes instead of an atrial catheter, there will be something that's used as an ablation catheter or a catheter in the coronary sinus, which records atrial electrograms. And what you can recognize is, look at these atrial electrograms. There's so few of them, but ventricular electrograms are numerous. So same diagnosis, more V's than A's, ventricular tachycardia. What about this one? So look at this one now. Little harder. I'll give you a second to look through it. First, you look up at the EKG and you say wide complex tachycardia. If anybody can see P waves in there, you have got really good eyes. They're really tough. I can't see anything that I would reliably say are P waves up on this. But then we know we have catheters in the heart. And what do we notice here? Look at the ventricular electrogram. There is a V for every QRS. So ventricular electrograms, as many as the QRSs. Now look at the atrial catheter. There are also just as many as there are QRSs. So for every V, there's an A. But there are two major clues that would allow you to diagnose the cause of this arrhythmia. First, notice that the V and the A are almost simultaneous. How does that happen? If it's a VT, it's got to take some time to go from the V to the A. If it is an atrial tachycardia, it's got to take some time to go from the A to the V. They're together. The V and the A are together. The second big clue, if you notice, on the His bundle tracing, the V and A are bunched up together, but before that, we have this His bundle tracing. So how do you get a tachycardia where the V and A are together? For that, we have to understand something about AV and RT, which I'll cover in the SVT talks a little later today. But basically, what happens in AV and RT is you have atrium that goes to the AV node and back to the atrium and to the ventricle simultaneously. So it's almost like a branch point from the AV node going to the A and the V. So since it's from one point, you're going to two structures, they can both get activated at the same time. So AV node reentry would be the arrhythmia overwhelming odds when you have both V and A at the same time. This is kind of a picture of the circuit. You're traveling down into the atrium. That's where you'll generate the His bundle. Imagine the circuit at this point, the electricity here. You go to the A, you go to the V, so it's no real conduction between A and V. It's from a common point you're getting to both A and V. That would be characteristic of AV node reentry. Now, one of the things we learn about AV node reentry is folks who have AV node reentry, like most of us, we have two different ways of getting from the atrium to the AV node, two different atrial connections to the AV node. Now, how you know that it's pathological in somebody is by looking at this very simple maneuver. Just try to follow with me here. So here we have surface, atrial pacing, captured the A, got to the His, got to the V. Captured the A, got to the His, got to the V. But now, instead of just pacing the atrium at the same rate, we put in an extra stimulus, which is like a PAC, just pacing the atria quicker than all these other beats. Now, when we do that, we're stressing the system. We're just pushing and seeing like what's going to happen. And what's happening here is, well, it's taking a little longer to get to the His bundle. That's normal. That's what our AV node is supposed to do. If things speed up in the atrium, it's supposed to delay to protect the ventricle from very rapid rates. But now when we put another PAC, this PAC we put like 330 milliseconds after this paced beat. This one is just a little bit tighter, little closer, 320 milliseconds. And now notice, huge change in getting through the AV node, and then it's off to the races, start of tachycardia with V and A that are simultaneous. This is typical of AV node reentry. The AV node, like all of us, does tend to decrement or take longer when it's stressed, but it does it abruptly because there are two different connections to the AV node. All of a sudden, it takes a long period of time, and that allows setting up the circuit of AV node reentry. Couple of intracardiac tracings in other SVTs. And again, we'll cover the mechanisms of this SVT in detail later today. But patients who have, instead of just the AV node as a connection between their atrium and ventricle, have an accessory pathway. Remember, in the normal heart, the whole annulus is insulated. The only way to get from A to V or V to A is through the AV node. But folks who have this accessory pathway, it's like a little breach in the insulation. And when you have that, that sets up the possibility of some tachycardias. What are they? Well, since you have two ways to get from A and V, you could go down the AV node and back up to the atrium through the pathway. That's orthodromic reciprocating tachycardia. You could do it the other way around, where you enter the ventricle through the accessory pathway, and that's antidromic reciprocating tachycardia. We'll go through each of these later, but let's look at some intracardiac tracings if we could figure it out. It's actually pretty simple. Just think of this. If I made it down the AV node to the V, if I put catheters all over the heart, say all in the coronary sinus, and say some catheters on the right side of the heart, if it's the AV node that's being used to get from V to A, whatever electrodes I have near the AV node, like the His bundle catheter, that should be the earliest atrial signal. That should be where you break from V to A. But if the earliest atrial signal is way over here on the side of the heart, then it's not AV node. It's got to be something else that's allowing that current to leak through back to the atrium. That would be an accessory pathway. So how do we recognize that? Again, start with the EKG, QRS complexes. Look at the ventricular electrogram. Then these electrograms, which don't line up with the V, they're all atrial electrograms. Now you just visually look at them and say, what's early? Which place activated first in the atrium? Is it the right atrium? No, because that's even later than near the AV node, the His bundle atrial electrogram. But way out deep in the coronary sinus, you have the earliest atrial electrogram. So how are you getting from V to A? From V to A, you're getting out through some connection on the left side of the heart, deep in the coronary sinus. That's an accessory pathway. This would be a patient who has a WPW-related arrhythmia. Sometimes we have a bunch of electrodes in the coronary sinus to help us pinpoint exactly where that earliest spot is. And when we find that earliest spot, we actually can recognize a signal where the accessory pathway is, and that's what's targeted for ablation. As you know, patients with WPW are kind of becoming an extinct species because all of them are getting ablated early in life. It's a curative procedure. Once it's ablated, it's gone. Now, for the boards, there is a couple of things that you should appreciate about WPW, which I'll cover in the afternoon lecture. But the key thing is antidromic reentrant tachycardia is always going to be a wide complex tachycardia. So remember the simple thing between orthodromic and antidromic. Antidromic, you're going down through this pathway to get to the ventricle. So it's just like VT. The ventricle is getting activated first. Antidromic tachycardia, regular wide complex tachycardia. Just skip ahead. I'll cover this in the afternoon talk, but want to go through a couple of questions with you and then discuss the answers a little bit. So here, this is a management question, and I'll show you the intracardiac tracing in just a bit. So this is a 48-year-old with hypertension, cigarette smoking, palpitations, and had this rhythm abnormality in the EP lab. And what will come back, and I'll show you the choices, but is it going to be verapamil, a defibrillator, amiodarone, or are we going to ablate something? So look at this. Just like before, the wrong reaction when you get intracardiac tracings is going to be, shouldn't have some funny feeling in your stomach and say, I'm never going to understand this. It's simple. It's actually simpler than reading EKGs, much simpler. But you look at this, you see EKG, then you see V for every QRS, but look, there's an A for every QRS also. V and A together, and there's a His bundle out in front. So every V has an A, but the V and A are simultaneous. So now we go back, and I'll take your responses. What will be your treatment of choice once you have this diagnosis? Is it verapamil, defibrillator, amiodarone, or some ablation in the ventricle that is near the mitral valve? Okay, fair enough. So you're right. Always think ablation when there is arrhythmia. But you don't ablate in the ventricle. You don't ablate in the mitral valve region. So what this is AV node reentry, AV node reentry. Those of you in EP know there are a lot of exceptions to everything we say, but 99% of the time, if the V and A are together, it's going to be AV node reentry. The appropriate options here would be verapamil, always good to do medical therapy to see if symptoms go away. Ablation can be a first-line therapy, but the ablation is done nowhere near the mitral valve. It's actually done on one of those atrial inputs to the AV node called the slope pathway, and I'll describe exactly where that is anatomically in this afternoon's talk. What about this one? The most appropriate course of action for a 70-year-old with hypertension and diabetes. If this were the only abnormality seen on EP testing for syncope, so patient had syncope and you're doing EP testing, what would you do? Would you do a pacemaker? And if you do, is it a VVI or DDD pacemaker? Would you treat with a drug like ephedrine or theophylline? Or just say, no problem, good EP study? So look at this. So P wave, QRS, A, His, and then V. Oh. So choices. Okay. I would agree with that. So here the key is the patient, the reason you're doing the study is syncope. So with the syncope, you notice it's taking a very long time to get from the His to the V. To be fair, you should realize this number over here, it's exceedingly long. It's like 96. Normal is like 35 to 55. So then you say infrahisian conduction disease. Most of the time, if you continue the EP study, it'll be a very clear decision because you'll also see infrahisian block. But just seeing this infrahisian conduction disease, patient has syncope, this would be an indication for a pacemaker. Now, what kind of pacemaker would you put? You'd put a dual chamber pacemaker because you like to have atrioventricular synchrony. When the patient paces, if they're only pacing in the V and they have sinus rhythm, that's going to be uncomfortable for some patients. Good rule of thumb, as long as they're not in AFib and you're putting in a pacemaker, it will be a dual chamber pacemaker. Just do one last one here. Patient with this tracing during an EP study, what will you do for treatment? Is this going to be a defibrillator? Do you think this patient is at risk for AFib becoming ventricular fibrillation? In other words, is there an accessory pathway? Do you think this patient needs ablation, but it would be near the AV node, so it's a high risk of AV block? Or be ready to put a ventricular pacemaker after the EP study because of some AV block type issues? So look at this and see. this is the EKG, ventricular electrograms, atrial electrograms. And I'll take your answers here, and this will be, and we'll be done. Sure. Very good. So again, very easy when you have the intracardiacs, more V than A, ventricular tachycardia, you induced it in the EP lab, most reasonable choice there will be a defibrillator. So remember, very few things to remember for the boards. A, His, and V, recognize it and tell the difference between the type of blocks. That's pretty much it. Thank you for your attention.
Someone had asked about what the crossfield V's were, so could we have Dr. Asirvatham's question number 1 up quickly, the ECG? Just make a quick point about that. To the ECG tracings, the very end, the questions. Okay. There was a question about, this one will work, a question about when we're looking at some of the CSs where you have a big, tall, skinny signal and you also have a smaller one. And do you want to make a quick comment on that?
First, I would say don't worry about it. It's actually not thing. But if you're an EP person, you know that the coronary sinus is on the mitral annulus. So because anything that's on the annulus, it's going to pick up both A and V. But remember where the CS drains in, it drains into the atrium. So it's a little closer to the atrium than it is to the ventricle. So you'll see the atrial signals are sharper or more near field, closer to the catheter, and the ventricular signals are a little further away, so look blunter and smaller sometimes, or far field ventricular electrograms.